Hello, everyone. My name is Levent Trabzonlu. I'm a soon-to-be graduated cytopathology fellow at Mass General Hospital. I'd like to thank the coordinators of the meeting and Dr. Akbalat for this opportunity. Today, I'm going to be talking about the second edition of the Paris system, also referred to as TPS 2.0. Just a mandatory slide for the money that I'm not receiving. So the second edition of the Paris system was published rather recently in 2022 with this cover. When we go 6 years back, we don't see a lot of differences between these two covers. The editors are the same, maybe their order is different. This yellow turned orange, but overall it looks quite similar to the first edition, right? And this is going to be the theme for this whole talk. Of course, there's important data that came out in the second edition, and a few changes catch your eye at first sight, but that's about it. This first edition was published in 2016. As we all know, the history of diagnostic studies of urine goes way back, but I'm not going to be talking about that for this presentation. But I strongly, highly, wholeheartedly recommend this brilliant chapter that the late Dr. Pomuchin wrote for the second edition of the Paris system. And it must be one of the best historical write-ups in medicine, if not the best one. I was lucky enough to get glimpses of his extraordinary mind during my residency. And when I read this chapter after his passing, it truly felt like one of those sign-out sessions we had. I honestly talk about him for the next 40 minutes, but that's not why we're here. But he was an incredible human being and he is dearly missed. All right. So when we look at the biology of what we're dealing with, we know that there is a low grade and there's high grade urothelial carcinoma. Low grade urothelial carcinoma comprises about 80% of all urothelial carcinoma cases, and it's always associated with clinically visible papillary growth. On the other hand, high-grade urothelial carcinoma is often flat, and these are the ones that cause invasive and metastatic disease. And these two diseases are descendants of two different pathways, hyperplasia and dysplasia pathways. We knew all of this stuff for decades, right? But what is new then? Well, between the first and second edition of Paris, TCGA Research Network published a comprehensive study describing the molecular characteristics of urothelial carcinomas. Based on this data, four molecular clusters are recognized. Given the heterogeneity of bladder cancer, there's significant overlap between these molecular clusters. One thing to note is that even the TP53 mutations rarely co-occur with the molecular alterations characterizing the FGFR3 pathway, which is the signature alteration of the hyperplasia pathway. In the end, these two pathways can actually have overlap when we're dealing with a muscle invasive disease. All that said, the morphological definition of high-grade urothelial carcinoma is pretty much the same. We need to see the increase in C ratios, nuclear hypochromasia, chromatin abnormalities, and nuclear membrane irregularities. And we're pretty good at recognizing that, right? What we're not good at is this. Since low-grade urothelial carcinoma does not show any of those features that I just talked about, it is often impossible to tell it apart from benign urothelial cells. And this is a nice ahead comparison of low-grade urothelial carcinoma and deep urothelial cells. There are multiple studies in the literature showing how we cannot make this distinction reliably and reproducibly. However, as Dr. William Murphy writes in his prologue for the first edition, that is not a weakness, right? Because urine cytology is meant to diagnose the clinically important high-grade urothelial carcinoma, which is capable of local invasion and metastatic spread. And the second sentence was repeated multiple times, both in the first and second editions. The guiding principle for the Paris system is to detect high-grade urothelial carcinoma. So how are we going to detect high-grade urothelial carcinoma? Well, we already know it has increased NC ratio, and that is the main branching point on this algorithm. And then we look if there is hyperchromasia, coarse chromatin, or irregular nuclear membranes. If at least two of these features are present in more than 10 cells, then we have a high-grade urothelial carcinoma. If only 5 to 10 cells, maybe less than that, meet those criteria, then we are at suspicious. If you have high NC ratio cells uh, that show one of these features, then we are at atypical. If there's any reason to cause atypia, such as polyomavirus, granuloma, prior surgery, urolithiasis, then we call it negative. Most of these criteria were established in the first edition anyways. Between the first and second edition, collective evidence showed that these criteria are effective, therefore they stayed the same for the most part. And this is a nice visual addition in the second chapter. It provides a good visual reference for NC ratio estimation. One striking thing to me is that the images for 0.7 and above look like they have almost no cytoplasm, right? And I'll come back to this later on during this presentation. Since we are dealing with a cytologic specimen, we have to talk about adequacy criteria, right? Any abnormality warrants an adequate diagnosis, as in the other classification systems. If that's not present, then we look at the collection method. Um, so if we're dealing with an instrumented specimen, we expect to see some cellularity. The cutoff number on that is 20 well-preserved urothelial cells per 10 high power fields, but there's scarce data for different preparation methods in the literature. In voided urines, it is okay to have low cellularity as long as the volume is enough, because not a lot of cells are expected in normal urines anyways. The cutoff number for the urine volume has been postulated to be over 30 milliliters, but again, the data on this is quite scarce and more studies are needed to establish the target numbers for different preparation methods. And this is a nice graph from a Johns Hopkins study showing percentages malignant and suspicious for malignancy diagnoses by volumes received. You can see that the peak of the malignant curve is around here at 27.5 milliliters. And based on this, the authors concluded that at least 30 milliliters is necessary to consider a urine fully adequate if voided urine. We could see some obscuring elements, and these should be considered non-diagnostic. For example, here we only have lubricant with no urothelial cells. On this one, there are scant cells with obscuring blood in the background. And this one has obscuring inflammation and a few epithelial cells. Although these are non-diagnostic specimens, as the morphology is not well appreciated because of the obscuring elements. So what can we see in normal urine? Well, we can see urothelial cells, squamous cells, glandular cells, and obviously degenerative changes. The most superficial urothelial cells are called umbrella cells. These cells have a large frothy cytoplasm and low NC ratio. They sometimes show this incomplete thickened cytoplasmic edge, which is a helpful clue for recognizing them. Then we have intermediate cells. These cells have a fried egg appearance, and they look like the parabasal squamous cells that we see in PEP tests, right? Again, the NC ratios are quite low, and the nuclei have smooth borders. And these are the deep urothelial cells from the previous slide that I showed. And the NC ratios are higher in these cells, but they're in a monolayer sheet, and they're quite round and uniform, nicely spaced out. Sometimes the urothelial cells come in fragments, as you can see here. These groups have quite uniform nuclear size and again, round shapes. It looks like a papillary proliferation, but this is an instrumented specimen, so it's okay to see these fragments in those specimens. And this one again shows round to ovoid nuclei with mild nuclear irregularities. NC ratios are still lower than 0.5 in both of these groups. And these fragments are called benign urothelial tissue fragments, and it does not warrant an atypical diagnosis. In comparison, these fragments show increased NC ratio with nuclear irregularities and abnormal chromatin. In these groups, it is harder to assess the NC ratios because of the third dimensionality. So it is better to be conservative in these situations. In this picture, we have a much worrisome cell right down here, and it's very convincing for high-grade urothelial carcinoma. Not this group, but this one is quite suggestive of high-grade urothelial carcinoma. On the right, we see quite hyperchromatic nuclei compared to these background normal cells. These are quite hyperchromatic. Uh, and these have irregular borders around here, but the NC ratios are okay. And this case has a history of nephrolithiasis, so it's okay to place this one in negative category. Since these groups have several atypical features, they are termed as atypical urothelial tissue fragments. The presence of atypical tissue fragments is associated with an increased risk of high-grade urothelial carcinoma when compared to the benign urothelial tissue fragments, as you can see here. But it's much more commonly associated with nephrolithiasis. Also, when you look at the risk of malignancy for atypical category, atypical urothelial cells, it's much higher than the risk of malignancy for atypical urothelial tissue fragments. None of these come close to this low risk of malignancy. Therefore, the Paris system recommends a high threshold for classifying atypical tissue fragments as atypical. And this is a nice poster picture for atypical tissue fragments. This is a small atypical fragment with hyperchromatic cells. It has irregular nuclear membranes, and the NC ratios look quite high, quite worrisome. And but it's hard to evaluate because it's in a again fragment. And it is right next to this X-shaped crystalloid material. Presence of crystals can account for mild atypia in tissue fragments. Therefore, we can put this into negative category rather than atypical. So remember this X over AUC. Benign glandular cells can be present, and this is a nice example of cystitis glandularis. The glandular cells are columnar and uniform with a bland chromatin pattern in this picture. We can also see renal tubular cells in the urine. They can present with scant cytoplasm, or like in this one, large vacuolated cytoplasms. This is a tubular cast in a patient with renal failure. Degenerative changes are common, especially in voided urines, because turns out urine is not the best preservative solution. Sometimes the urine samples sit on the bench at room temperature and it quickly causes degeneration of the cells. Here we see a lot of cells, cellular debris, and some small pycnotic nuclei. Sometimes it can be concerning for urothelial carcinoma. However, note that the cells are quite small. But specimens with degenerated high-grade urothelial carcinoma cells often show larger cells. And this is a nice example of that. You can see that these nuclei are much larger than this inflammatory cell, and they have irregular borders with hyperchromasia. Malignant Wolinska bodies are also well known as a degenerative change in urine specimens. And sometimes degeneration could be so prominent that the cells may appear to have high NC ratio, like this one here. But as you can appreciate, the interface between nucleus and cytoplasm is blurry at this one. Therefore, we cannot include this cell into our evaluation. We can also see various infectious processes in the urine, such as HSV, polyoma virus, and schistosomal. And these are some examples of infectious agents. Here we see the classic multinucleation, molding, and chromatin margination of HSV. Here in the middle is a nice example of schistosoma. We can also see Candida in urine specimens, particularly in patients with neurogenic bladder and in specimens with vaginal contamination. Enlarged nuclei with chromatin homogenization, spiderweb appearance of the cytoskeleton, and glassy nuclear inclusions are classic features for polyomavirus effect in urine cytology. But as we all know, we can still see high-grade urothelial carcinoma in specimens showing polyomavirus effect. In fact, 2 studies found increased risk for high-grade urothelial carcinoma on follow-up when atypical cells are present in addition to polyoma virus effect compared to those lacking atypical cells. So careful examination is warranted on these specimens. As we all know, bladder cancer patients undergo multiple rounds of immunotherapy, and some of them undergo definitive surgery with urinary diversion. In divergent specimens, there are usually abundant degenerated enteric cells and a few urothelial cells, if any. Sometimes guar is used as an adhesive material on the skin around a urostomy stoma. It can be a pitfall for high-grade urothelial carcinoma when presents in an unusual appearance, so uh, uh, we need to be aware of this entity. Multinucleation with cytoplasmic vacuoles and low NC ratio are classic features of radiation-related changes. Patients may receive radiation to the urinary tract to treat a primary malignancy, or the urinary tract can be exposed to radiation due to treatment of an extraurinary malignancy like cervical cancer. This is a classic image of a tight cluster of epithelioid histiocytes, also known as a granuloma. Intravesical BCG therapy is known to cause granulomatous inflammation, and that may be seen in urine specimens. And this is another tight cluster of cells, but these have flagella, as you note here, because they are spermatozoa, and the arrow points to this nice lipofuscin pigment of the seminal vesicle cells. These cells can mimic high-grade urothelial carcinoma because of their large size, and nuclear hyperchromasia can be present, but the clues of spermatozoa and the lipofuscin pigments usually come with it. As you all know, cytologic classification systems have indeterminate diagnostic categories between negative and positive, as much as we try to avoid. In most of the laboratory tests, there's a small fraction of cases where features may resemble the presence of disease while the patient does not have the disease, or the findings in a patient with the disease might not be clear-cut malignant because of degeneration and other reasons. And that forms the domain of atypia for cytologic tests, including urine cytology. The authors of the pair system did a great job in defining the borders of this domain. Just to refresh our minds, these are the features of high-grade urothelial carcinoma: high-NC ratio, nuclear hyperchromasia, nuclear irregularities, and chromatin abnormalities. And let's do some exercise. The image on the left shows 2 flat sheets of urothelial cells. The one on top is clearly benign, comprised of uniform round cells with low NC ratio. The one at the bottom looks different though. It is not as orderly as the other group, and the nuclei are larger, more irregular, and NC ratios are definitely increased, as you can see here. But when you compare the 2 groups, you don't see clear hyperchromasia, right? It's quite close to each other. Similar thing on the right side. We have a small cluster of benign urothelial cells on the far right, and these ones are clearly larger, more irregular, and some of them have high NC ratio. But again, the chromatin pattern is quite smooth in these cells. and the nuclear chromasia between these two groups are not different at all. So we're falling short of features of high-grade urothelial carcinoma in both of these pictures. Okay, now we have another set of worrisome pictures. On the left, we have nuclear irregularities clearly and high NC ratios. The chromatin pattern is still finely granular, but we can probably argue there is some hyperchromasia. One thing is that this is a tissue fragment, and we don't see any isolated cells or flat sheets that we can see the NC ratio clearly. Therefore, the evaluation of NC ratio is somewhat limited. On the right side, this one cell has a very high NC ratio. The nuclear membrane looks irregular, but it looks like a little degenerated, right? It's the nucleus is almost pushed off from the cytoplasm. Both of these cases had urolithiasis and were negative in the follow-up. In the absence of history of urolithiasis, a diagnosis of atypical would be justified in both of these cases. And another set of images. In these groups, we have increased NC ratios with enlarged nuclei, hyperchromasia, but the chromatin pattern is mostly okay, with maybe occasional nucleoli, and the nuclear borders are very smooth. Again, on the right side, there's increased NC ratio, hyperchromasia, and coarse chromatin, but it shows remarkably smooth nuclear membranes, no irregularities, no indentations at all. And there's also some degenerative changes in the cytoplasm, as you can see here, some vacuolation here. Both of these cases were called atypical and turned out to be high-grade urothelial carcinoma, but it would be wise to pull back to atypical in this type of cases. Smooth nuclear borders, some degeneration. Gotta be careful. Considering all of these gray zone changes, the Paris system takes a probabilistic approach, defining the criteria for atypical urothelial cells. It appears that the increased NC ratio above 0.5 provides a high predictive power for high-grade urothelial carcinoma among the features of high-grade urothelial carcinoma. And it's the most reproducible one. Therefore, it makes sense to have the high NC ratio a required criterion for calling something atypia. Then if you have any of the other features, you can call it atypia in the absence of factors that can cause atypia, as I mentioned before. But then the question of degenerative atypia raises, of course. When you call all cells with high NC, with NC ratio lower than 0.5 non-atypical, you leave these degenerated but clearly irregular and hyperchromatic nuclei out, right? Both of these cases were called atypical due to the hyperchromasia and nuclear irregularities. And the one on the left turned out to be high-grade urothelial carcinoma, and the one on the right is a case with urolithiasis. Granted, the case on the left has this one cell with higher NC ratio, close to 0.5, and would get an atypical diagnosis by strictly applying the criteria anyways, but cells like these form a basis for objection to the NC ratio criterion. But the second edition has a great answer to that. Applying the Paris criteria for atypical urothelial cells, the frequency for atypical has been reported around 10%, and there's no overlap in terms of risk of malignancies with other categories. Also, multiple international studies reported a significant decrease in their atypical rates after utilizing the Paris system. There's only one group from Spain reporting an increase in their atypia rate utilizing the Paris system, but their pre-Paris atypical rate was exceptionally low to begin with. So the evidence shows that the criteria for AUC work in various settings and help decrease the atypia rate while accurately stratifying the risk of malignancies. Not much has changed in the suspicious category. It means that we have all the features of high-grade urothelial carcinoma in a very limited number of cells. And these are some examples of suspicious for high-grade urothelial carcinoma cases. These rare cells have very high NC ratio with enlarged nuclei, irregular nuclear borders, and coarse chromatin. These these cells down below look similar, but when we look closely, this group does not show chromatin abnormalities. It's got very smooth chromatin. And these two cells are degenerated. They have quite high NC ratios and they're very hyperchromatic, but we need to see all features of high-grade urothelial carcinoma cells in intact cells in order to be able to render the suspicious diagnosis. As I mentioned before, the guiding principle of the Paris system is to detect high-grade urothelial carcinoma. Therefore, the defining criteria for high-grade urothelial carcinoma needed to be established in the first edition. Based on available evidence at the time, they determined that these four criteria would be required to make the diagnosis of high-grade urothelial carcinoma. And indeed, it worked. All studies utilizing these criteria for high-grade urothelial carcinoma reported over 90% specificity. Therefore, the Paris system decided to keep them with minor changes to make the diagnosis. As you can see, there's an asterisk next to hyperchromasia. That's because between the first and second edition, there have been several reports noting that there's a hypochromic variant of high-grade urothelial carcinoma. Therefore, the Paris system recognizes this morphological variant and requires two of these three non-numerical criteria, but the NC ratio is still there and strong, and I highlighted it in red, but not for that reason. The threshold of 0.7 have been questioned by multiple studies. This study used digital image analysis to look at the NC ratio of the cells in urines that were reported as high-grade urothelial carcinoma or suspicious for high-grade. And they found that most of these cells don't even pass the threshold of 0.7, and the average NC ratio was 0.57 for high-grade urothelial carcinoma, and it's only 0.53 for suspicious for high-grade. But they mentioned that they saw at least some cells that have NC ratio of over 0.7 in almost all samples with high-grade urothelial carcinoma. Another interesting study challenged the NC ratio criterion from a different perspective. This group showed numerous images of cells to various people from various backgrounds and wanted them to estimate the NC ratios of the cells. As you can see here, people with pathology training did worse than analysts in estimating NC ratio. The residents did slightly better than the pathologists and cytopathologists. And all morphologists have one thing in common. They tended to overestimate than underestimate the NC ratio. And this is actually quite striking to me. They looked at the accuracies for different NC ratios, and interestingly, there was significant overestimation at 0.4 and 0.6, which are the approaching points to our very powerful cutoffs of 0.5 and 0.7. And circling back to this diagram, the Paris system actually took the diagram from this paper. It is really difficult not to call these cells greater than 0.7, right? The Paris system addresses these imperfections about the NC ratio criterion, but it's still the most powerful and reproducible predictor for high-grade urothelial carcinoma, despite its shortcomings. So they kept it as is for now. And here's a classic picture for a high-grade urothelial carcinoma, right, with all of its features in display. But life is not always this easy, and we can see cells like this, which has prominent hyperchromasia, nuclear enlargement, and nuclear irregularities and coarse chromatin. But the NC ratio is quite low, as you note here. The qualitative features are enough to call this high-grade uh, urothelial carcinoma if more than 10 cells like this are present. If not, we can call this suspicious. Another example of clearly malignant cells with low NC ratio. As you know, urothelial carcinomas can show glandular differentiation and it can have a low NC ratio. But again, the qualitative features of nuclei are enough to make the call. And the infamous plasmacytoid variant of high-grade urothelial carcinoma shows this eccentrically located, enlarged, hyperchromatic nuclei. But again, the NC ratio on the cell is lower than 0.5. Therefore, when we have the nuclear quality for high-grade urothelial carcinoma, it is okay to call these cases positive, even the NC ratio is low. Urothelial carcinoma is the most common type of malignancy in the bladder, but we can see some non-urothelial neoplasms as well. And squamous cell carcinoma is the second most common histologic type after urothelial carcinoma in the bladder. Again, you cannot be strict in using the NC ratio when there's clearly dysplastic squamous cells in the urine. Note that dysplastic squamous cells in the urine are most commonly seen in urothelial carcinomas with squamous differentiation. In cases with pure dysplastic squamous cells, we can suggest that there might be a primary squamous cell carcinoma of the urine, urinary bladder. And this was a case I saw during my fellowship, and I wanted to share this one with you. Here we see a tight cluster of hyperchromatic cells with scant cytoplasm. Looking at the background inflammatory cells, these cells are not as large as your classic urothelial carcinoma, and the chromatin pattern here is quite homogeneous. Maybe a little uh, coarse chromatin on this one, maybe here. Um, but overall, the chromatin pattern is quite smooth. Uh, then we on this slide, on this photo, we see necrosis. It's possible to see necrosis in urothelial carcinoma, but that's not a usual finding in a urine cytology. This constellation of findings would bring small cell carcinoma to the differential diagnosis, and indeed, the subsequent cystectomy showed a primary small cell carcinoma of the bladder, and this is a higher power picture. In upper urinary tract, most of the definitions and criteria are the same with minor exceptions. Since we always receive instrumented specimens from the upper tract, the volume criterion does not apply for these specimens. We need to see appropriate cellularity. The cutoff for that is the same, 20 well-preserved cells in 10 per 10 high power fields. But again, there's scarce data in the literature and further studies are needed to determine the magic number here. The criteria for high-grade urothelial carcinoma in the upper tract is slightly different. It requires more than 10 cells as opposed to more than 5 to 10 cells in the bladder. The reason for that is to increase the level of certainty because it may be difficult to obtain a tissue biopsy from some upper tract lesions before the definitive treatment is applied. And this is the case where I will make my final point. This was the only case I have seen during my fellowship for this entity. You can see a large fragment of beautiful papillary structure on this left one. On the higher power, you see the clear fibrovascular core and the lining epithelium doesn't have any of the high-grade features. We ordered a cell block on this specimen and again saw these gorgeous papillary fonts with fibrovascular core. And again, the urothelial cells are orderly with no high-grade features. So we call this case an Elgon. This was a separate category in the first edition, and it was reserved for these rare cases. There are 3 series in the literature with more than 10 Elgon cases, and the risk of low-grade urothelial neoplasm for this category has been reported between 45% to 100%. Risk of high-grade malignancy, on the other hand, was between 0% and 54%. But again, the number of L-GON cases in these studies were extremely limited because it's a very rare scenario overall. Additionally, when you look at the retrospective urine specimens of cases that were reported as low-grade urothelial neoplasm on histology, the majority of those cases were reported negative. Thus, L-GON was not offered as a separate category in the second edition. However, the circumstances in which we can make a diagnosis of L-GON were described, as I mentioned in the previous slides. But in the sample reports, the top-line diagnosis was recommended as negative for high grade. And, and then L-GON was placed in the second line. Therefore, it is now embedded in the negative category. But we have not reached a consensus on that front. This is a recent international survey report by the editors of the Paris system, and it looks like there's still significant variation in practices of reporting L-GON. The Paris system prefers reporting negative for high grade as top line, and about 52% of participants agreed with that. So there is still more work to be done on that front. With that, I'd like to thank you for listening to this presentation, and I will be happy to take any questions. Thank you.